Herzlich willkommen zu einer Stunde Orthopädie. Welcome to an hour of orthopedics, an interesting topic, personalized knee replacement. My name is Henning Windhagen. I am head of the orthopedic clinic at the Hanover Medical School. Next to me is Thomas Grupp. He is professor of biomechanics at the LMU in Munich and head of research from Braun Esculap. Und neben ihm haben wir meinen Kollegen. Next to him we have my colleague Georg Matziolis. He is the ordinary of orthopedics at the University of Jena. Welcome, friends. We have an interesting topic, phenotyping. It sounds complex somehow, Georg. Like all knees are somehow different. Is that so?
Alle Knie sind irgendwie anders. Ist das so?
That's how it is. We've known that for many years. We learn it in orthopedics. In our studies, there are straight legs, X legs, O legs. As a surgeon, you see wide femora, narrow femora, deep femora, and tibial torsion. So if you look at the geometry, we've certainly come further since then. We'll talk about paying attention to anatomy in the lectures, but the next step is also to look at function, meaning what kind of kinematics is there. Surgeons are increasingly taking a more individualized approach to these patients and inserting their implants accordingly. And the question is, how far can we go? Is this all just experience and a rough estimate, or is there support? I think that's also what we're talking about today. How can technology support us in the future?
So, und die Implantate. And with the implants, we take standard implants and try to personalize them. Thomas, have the companies already realized this?
Angekommen?
Ja, auf jeden Fall. In den letzten 2 Jahrzehnten. Yes, definitely. Over the last 2 decades, we've focused heavily on optimizing materials, improved polyethylenes, coatings, new implant designs, and even more precise implantation instruments. This has demonstrably improved long-term results in knee arthroplasty. Today, the focus is on individualization and personalization. We're essentially trying to focus on the patient's axial alignment and gait, and to address these topics with the appropriate implant platforms.
Plattformen, diese Themen zu adressieren.
So, liebe Kolleginnen und Kollegen, wir wollen Ihnen das...
So, dear colleagues, we want to present a diverse range of topics to you this evening. We'll be giving presentations and we'll show you cases later, but of course we also want you to participate. You can find a place to enter questions on the right-hand side of your screen. We'll discuss these questions with you later. Please join in so we can make this as interactive as possible.
Interaktiv hier hinkriegen. Und wir haben uns natürlich auch so ein paar Fragen überlegt und Sie können sich schon vorstellen, die sind so ein bisschen vorher und hinterher. Vielleicht lernt man ja auch.
And of course, we've also thought of a few questions, and you can imagine they're a bit before and after, so maybe you'll learn something. In any case, we can discuss the topic, and we want to start with an initial live vote with actually quite simple questions, but they're a bit challenging. The first question would be, do our patients today have higher expectations of the results after a knee replacement than they did 20 years ago? Yes or no?
Ja oder nein?
Younger people may answer that differently than older people, but that's the first question. The second would be, have surgical outcomes after knee replacements improved at all in the last 20 years? That's a lot of evidence, but it's also a bit of a question of whether or not to feel. And if we now believe that we've actually improved, and most orthopedic surgeons believe that, then the question is it us, the surgeons?
Nicht besser geworden sind. Und die meisten Orthopäden, die glauben das ja von sich. Also, dann ist die...
Or is it the companies, the implant manufacturers? So is it the implant design? Or is it more the surgical technique? That would be the second or the most important topic for 10, 15 years. Robotics, navigation, and of course, what always plays a huge role, perioperative management with everything that goes with it, pain, leaf management, and so on. We've now answered that and we're dealing with it shortly.
Das perioperative Management mit allem, was wir drumherum haben, Schmerz, Blattmanagement und so weiter. Das haben wir jetzt beantwortet und da kümmern wir uns.
Now let's get into the topic, and Georg Matziolis will give us a brief talk on the topic of standard and why it's actually no longer enough today.
Kurz vortragen zum Thema Standard und warum das eigentlich heute nicht mehr genug ist.
Danke, Henning. Warum ist Standard heute nicht? Thanks, Henning. Why is standard no longer enough today? Regarding structure, patient expectations over the course of the year, now without the ceiling effect function, the new goal is no longer service life. Satisfaction can be increased. Total eine Prothese. And what are the limitations of a standard total hip replacement? Patient expectations, interestingly presented here, show the number of expectations for a hip and a knee replacement. I think most listeners will agree that the results are better after a hip replacement than after a knee replacement. Interestingly, the expectations are completely different. The number of expectations is higher for a knee replacement than for a hip replacement.
Die Erwartung ist an eine Knieprothese höher als an eine Hüfte.
This culminates in publications that even look at ultra trails after endoprostheses, meaning 300-kilometer races with 25 kilometers of elevation difference, and patients with hip and knee replacements even finish these races. It's understandable that this is somewhere near the limit for the equipment because it demonstrates that patients simply have high expectations for extreme sports.
Nachvollziehbar, weil es demonstriert, dass der Anspruch von Patienten einfach auch an extreme Sportarten da ist.
Then we come to scores that now exist without the ceiling effect. What is the ceiling effect? The ceiling effect means that classic scores, such as the Oxford knee score, no longer detect differences beyond a certain level of functionality and pain relief. That is, they can no longer distinguish between good, very good, and excellent patients. These are scores that were established many decades ago.
Sehr guten und exzellenten Patienten. Das sind eben Scores, die vor vielen Jahrzehnten etabliert wurden.
On the right, you can see newer scores like the high activity arthroplasty score, and there we see the classic bell curve again. This means that these new scores differentiate between good and very good patients. Here's a German version of this score published 2 years ago. You can see that it asks not only about walking, but also about running, climbing stairs, and even extreme activity levels. Relatively simple, that's just added up. Even longer established.
Extreme Aktivitätslevels. Relativ simpel, es wird nur aufsummiert.
The forgotten joint score has been established for several years. It consists of 12 simple questions that assess whether the knee joint that has undergone surgery can be felt. It shows that there are significant differences in the first 6 months after a sled implantation compared to a total knee replacement, although these differences level off again after 2 years. This means that this score is sensitive to detecting differences.
Dieser Score ist empfindlich, Unterschiede zu detektieren. Das nächste ist Funktion.
The next step is that function is no longer the new goal. We look at the German endoprosthesis register. The current version shows that after 10 years of widespread use in Germany, 90 to 96% of all total knee replacements have not been revised.
In situ sind nicht revidiert worden, sind altersabhängig.
Age dependent, meaning the red, blue, green, and yellow curves depend on the patient's age. This means that many of our patients have a very, very high chance of never having surgery again after a successful primary implantation.
Aber das EPRD erfasst.
But starting this year, the EPRD is also collecting PROMs, or patient-related outcome measures. This means patient satisfaction. The questions are based on the Oxford hip score, the knee score for assessing pain and function, and the knee score.
Ich gehe davon aus, dass damit das
I assume that this will make the clinical outcome just as transparent as the longevity. And at some point, this will also become decisive for selecting a clinic. This means we would all be wise to pay attention not only to the longevity of the endoprosthesis, but also to its functionality. Satisfaction can be improved. 20% of dissatisfied patients, this has been consistent in the literature for decades, including 13 studies in a meta-analysis.
Und das liegt daran, dass
And that's precisely because many expectations are fulfilled, shown here in black and gray. Fulfilled expectations meaning completely or somewhat fulfilled, meaning pain reduction, which works. Walking works, but not many things that are obviously important to patients are also fulfilled, and in particular, kneeling and squatting deeply, something that is still not well solved today.
etwas, was auch heute noch nicht gut gelöst ist.
Here's an older publication that focuses on this again. After a total prosthesis, only a third of patients are able to squat deeply. This may have improved somewhat with new surgical techniques, but I can also report from my own practice that the majority of patients after a total prosthesis have difficulty squatting deeply. After the sled, things look better. What are the limitations?
Nach einer Totalprothese eher Probleme hat, ganz tief in die Hocke zu gehen. Nach dem Schlitten sieht es besser aus. Was sind die Limitationen? Nun, die Limitationen, die beginnen.
Let's start with the technique of how we operate knees. Mikulicz established the so-called Mikulicz line in 1880. It's an imaginary line connecting hip, knee, and ankle. He first reported on it in his habilitation thesis on genuvarum and valgum.
Berichtet erstmalig. Das Ganze ist 1980 von
Insol took up the whole idea in 1980, and he described the resection perpendicular to the mechanical axis, the so-called mechanical alignment. And this is actually the most common way knees are implanted worldwide. In the meantime,
Inzwischen, Seit 2021 nach McDessie. Since 2021, according to McDessie, we have a CPAC classification that divides the knees into 9 different phenotypes, and we will also hear in the subsequent lectures that there are even more complicated classifications. That is, from simple we move to more and more complex. In order to differentiate, we look a little more at the stability than we see under A. Das native Kniegelenk, das heißt von der Streckung in die Beugung. In the native knee joint, that is from extension to flexion, from top to bottom, we see that the knee is rather lax. There is up to 5 to 4 millimeters of medial lateral joint play, and after implantation of a total knee replacement, the knee joint is significantly tighter. This has benefited the materials over the years, with the goal of minimizing wear. Über die Jahre, mit dem Ziel, but the surrounding soft tissues don't know anything about it, and they sense that something is different. And that can certainly contribute to patient dissatisfaction. That's the basic hypothesis. So the idea is to incorporate native laxity rather than this tight, rigid, polyethylene-focused laxity. To summarize, patient expectations have risen and continue to rise, and satisfaction hasn't increased over the decades. Zusammenfassen, der Anspruch der Patienten. We have new scores that crystallize this even better, that can objectively depict this imperfect function. Starting this year, the EPRD will be recording PROMs. And the longevity, in contrast to the function, is still not good, at least for knee prosthetics. Sorry, the longevity, in contrast to the function, is resolved. That's why I maintain that the standard knee prosthesis needs to be further developed if we want to improve this. Deswegen behaupte ich, die Standard-Knietap muss weiterentwickelt werden, wenn wir hier besser werden wollen.
Herzlichen Dank für diese schöne...
Thank you very much for this wonderful evidence. Very interesting. Georg, are we promising patients too much?
We do this with the hip. I don't think we promise much differently with the hip than with the knee, yet it works better with the hip. Patient satisfaction is higher. And so I believe it's simply the limitation of this more complex joint and not the expectations we generate as surgeons.
Generieren.
Yeah. Perhaps we'll upload the voting results, and I'll just ask Thomas briefly. In your opinion, what has the industry done most to improve knee replacement in the last 15 years? To improve.
In den letzten 15 Jahren bei der Entwicklung der Knieendoprothetik, um es besser zu machen.
Also sicherlich das Thema Material.
Certainly the material topic, such as age-resistant polyethylene and coatings for patients with suspected implant allergies. We have better designs and we have a much wider selection of sizes and finer gradations, more precise instruments, and then navigation and robotics, which support the surgeon in implanting the knee in a targeted manner.
Zielgerichtetes Knie einzubauen.
Prima, gut. Dann wollen wir doch mal gucken.
Great, fine, then let's see how we view the questions. And I think we have a pretty clear result, as if we had already seen your presentation beforehand, but I think that will become clear on its own. The higher demands are for everyone, and I suspect, now you notice that there are a lot of colleagues and experts, that's just the way it is. Evidence in old age, we can't get around it. We go straight to the second question, have the surgical results improved? And there it is also clear, and some agree with you, Georg, say no, but most say yes. That is interesting. So maybe the evidence and the feeling we have at home are a bit mixed up.
Georg sagen nein, aber die meisten sagen ja. Das ist interessant. Also vielleicht geht da so ein bisschen die Evidenz und das Gefühl, was man so zu Hause hat, doch ein bisschen durcheinander.
Nein, glaube ich nicht. Die Ergebnisse haben sich ja gebessert. No, I don't think so. The results have improved. If we look at older publications, let's just take the range of motion, that is the flexion capacity of the knee joint. Average values of around 100, 105 degrees were common 20 years ago, but today the average in current publications is 115, 120 degrees, which means it's objectively measurable. Have the results improved, but the patient's increased expectations are leveling this out.
The fact that this effect for high school and hedgehog running, not everyone has to run, is getting better for things to get even better.
That's what I think.
Gut, dann wollen wir mal gucken, wer schuld ist oder wo vielleicht der Kern des Problems.
That's a dilemma we're in. Okay, then let's look at who's to blame or where the core of the problem is, and that's interesting too. Which factors contribute most to this? Thomas, you said that robotics and navigation are also something. Is that so?
Sicher ein Aspekt, wobei da hatten wir...
It's certainly one aspect, although in the first step we only increased the precision of implementation, and now it's about identifying the patient and then individualizing them. So at the moment it's possible that we're missing the target very precisely, and those are the aspects, the factors that we can't identify in patients today that we need to address in the future in order to truly leverage the potential of robotics and navigation.
Navigation auch heben zu können.
Dürfen wir es bitte nochmal einspielen, das Ergebnis?
Can we play it again, please? The result that we're seeing again, Georg leads perioperative management. I would have thought so too. There's really something to it, not what the core of pain management is.
Überrascht mich nicht. Das ist ja die Phase. It doesn't surprise me because that's the phase in which surgeons perceive their patients most directly. That's the first day after surgery. Those are the first days on the ward. And there we certainly have information about current forms of anesthesia. With local infiltration analgesia and optimized preparation, we were able to reduce complications on the one hand, but also reduce pain on the other. I do believe that with simple things, namely tranexaminic acid, transfusions are now hardly needed in elective knee arthroplasty compared to 20 years ago. A lot has happened, so let's look beyond the first few weeks. I'm questioning whether the preoperative management really improved function in the medium and long term.
Okay, let's move on to another question for the audience. Imagine you're operating on a varus knee with a constitutional axis of 5 degrees, hip knee ankle angle of 175 degrees. How far do you set your limit for axial alignment when using a CR surface prosthesis? These are questions A through E. And these can be answered here, just like your own management. Whether the strategy is good for dealing with patients is something
Eigenes Management, Vorgehensweise, Strategie ist im Umgang mit den Patienten.
We'll hear about shortly, but first we want to talk briefly about it again. We just heard about the old standard. Now, whether the new standard is safe, and we have to ask ourselves what the new standard is.
Was mit dem alten Standard ist, jetzt, ob der neue Standard sicher ist und wir müssen uns...
And to sum it up, the new ideas in surgical technique are simply concerned with the soft tissue of the knee and what we see here, the ligaments and tendons, which are crisscrossed with pronouns and sensors, and if you tense the knee, we all know that it hurts, possibly permanently, and that is the basis of the whole idea of the constitutional knee. That there are some of us who were born with varus or who somehow acquired it in their youth.
Des ganzen Denkens das konstitutionelle Knie. Das ist also einige von...
And the others just have physiologically valgus legs, meaning X legs, and they cope wonderfully. And if we always do it in the middle like we did in the past, everyone with X and O legs, then we might strain the knee. And that's the reason why we've been thinking for 10, 15 years about methods that can essentially leave the knee as it was before. One method, for example, is kinematic alignment, and the whole discussion surrounding it, it's a method that's been very well researched.
Genommen das Knie so lassen kann, wie es vorher mal war.
Because for 15 years, I'd say we've had 18 randomized controlled trials, which almost consistently show that you have a better forgotten joint score, that the anesthesia mobilization rate is also lower, that the PROMs are a bit higher, everything functional so that the patient is a bit happier and a bit more satisfied. That's what's showing.
Mobilisationsrate niedriger ist, dass die PROMs ein bisschen höher sind. Also alles Funktionelle, dass der Patient also ein bisschen glücklicher ist und ein bisschen mehr zufrieden ist, das zeigt sich. Stellt sich nur die Frage...
The only question is, could this possibly be at the expense of the implant's longevity? We always have two things, function and long-term stability, if we look at this case. And I don't even mean the left leg, which is obviously grotesquely varus and certainly deformed, but look at the right leg too. It also has pronounced varus. And you have to ask yourself, can we leave it like this because that's one of the biomechanical truths?
Das ist eine der biomechanischen Wahrheiten und
Thomas Grupp, as a professor of biomechanics, says, of course, we can't get around it. These are the laws of physics. And they are, of course, important for us clinicians too, because that's the old story. We have to be careful that the implants are not overloaded. For those who also do corrective osteotomies and, of course, say we have to straighten the axis, let me just say that the cartilage cannot withstand as much as our new implants. We will come into that later.
Implantate, da gehen wir später noch drauf ein. Mittlerweile sind die
Polyethylenes are now so stable that it might actually work. To a certain extent, we could incorporate the knees kinematically because they function better there. But we just don't know where the limit is, and that's the interesting thing that concerns us at the moment. We simply can't get past the adductor moment. I think the most important study on this would simply be the one we keep looking at.
Ich denke, die wichtigste Studie dazu wäre einfach die, auf die wir immer wieder schauen, die in der wirklichen...
So, in the real world, this is a real-world experiment. And this is the study published by Trepczynski 34 years ago, based on the old so-called mining mandates, where they actually implanted a prosthesis into 6 patients to measure their strength. And the interesting thing is that in this study, the patients were distributed across different leg axes. And if we look at that now,
Das Interessante ist, dass in dieser Studie die Verteilung der Patienten in verschiedene Beinachsen war. Und wenn wir uns das jetzt mal sozusagen in Ruhe anschauen.
let's take a closer look, so to speak. This somewhat complicated diagram. Then we see how these 6 patients are distributed. So, on the x-axis, we have the leg axis from 0 to 6 degrees, varus, which is quite a bit of varus, and we see the measured load of the prosthesis. If we look at the cases, one of the patients had slight varus, almost straight leg axis, and little force. That fits with our old standard theory, just as it also says that the person with the highest upper adjustment feels the greatest forces in the knee.
Aber schauen wir uns die dazwischen an.
But let's look at the ones in between because that shows it's not that easy. This linear relationship isn't that easy because there aren't 2 in between who have almost the same leg axis of 3 degrees and almost twice or half the difference, or the other 2, where the load is essentially the same for someone with 0 degrees and 5. So at the moment, we can't say whether we should or shouldn't do it, but there seems to be a lot more influence from weight, strength, etc.
Von Gewicht, Kraft, Prothesengröße.
Prosthesis size has so many influencing factors for ensuring kinematic alignment safety, and we're talking about that today. We might need something like a biomechanical corridor and probably high-tech to better manage this in the future. That's the topic of this hour, and Thomas Grupp in particular will explain it in great detail.
Grupp uns auch noch sehr detailliert ausführen.
Gut. Schauen wir uns die Live-Voting-Ergebnisse an.
Okay, let's look at the live voting results. Regarding the viewer question, you can see that the vast majority, we wouldn't have expected otherwise, 50% follow the standard mechanical axis plus minus 3 degree corridor. How would you comment on the others, Henning?
Also, was mich ja mal richtig freut, ist, dass
What really pleases me is that no one is saying that the leg axis doesn't play a role. So, as I just said, I suspect we're dealing with a lot of experts. Then there are obviously some who are doing restricted, so they say 3 degrees, so you can give quite a bit more. That's my experience, and the interesting thing now will be whether, with your next ideas, we can perhaps convince even more of yours, whether we could perhaps stick with the constitutional approach.
davon überzeugen können, ob man vielleicht auch beim Konstitutionellen direkt bleiben könnte.
Ich hätte gleich eine Frage an dich, und zwar, I have now a question for you. Are there any patients who, in your opinion, represent a contraindication for such a constitutional alignment? Where you say, no, I'll stick with the classic mechanical alignment, even though I'm a fan of it?
Ja, ich glaube, dass wir schon noch viele solcher Fälle haben.
Yes, I think we still have many such cases. We have patients where we don't understand the kinematics of the knee. We have patients in their teens and 20s where we see that something is wrong with the knee's biomechanics, who develop osteoarthritis early on, who also have joint lines that don't fit the norm in our classifications, which are rare. We have post-traumatic conditions, and we also have problems where we see patients with atopic fibrosis after an infection, so there are many diseases of the knee. And I think that we need to take care of things rather than experimenting too much, and there is simply not enough experience with this yet.
Um die Dinge kümmern, als jetzt zu viel experimentieren und auch, es gibt einfach auch noch nicht genug Erfahrung darin.
So patella, you would also subsume maltracking under this. If the patella is not working well, it is not a good idea to repair it.
Wer seit der Jugend Patella-Probleme hat,
And if you have had patella problems since youth, and if we have not yet fully understood these knees, then it is probably not a good idea if we simply follow joint lines that we may also view as pathological.
Müssen wir uns erstmal darüber im Klaren werden, welche Patienten kommen dafür in Frage.
So we first need to be clear about which patients are eligible for this. I think the vast majority. And then when we look at the indication, where exactly the biomechanical limit is.
aber schon sehen, dass wir auch jetzt mittlerweile viel Erfahrung haben, dass man diesen funktionellen Vorteil...
We can see that we now have a lot of experience that this functional advantage is substantial, which means it's an opportunity. And I'd like to convince those who voted for 3 degrees that you can achieve a lot with these 3 degrees. But if you look closely at the studies, you'll see that those who stick with 3 degrees, there are many studies that restrict the kinematic alignment, meaning you don't go above 34 degrees, and that's where the advantage is already apparent. So I think this is an opportunity to look into the matter in more detail.
Der Vorteil auch schon zu sehen. Also ich denke, das ist schon so eine Chance, dass man sich tiefer um die Sache kümmern muss.
Spielt Kosmetik eine Rolle?
Does cosmetics play a role? We always say plus minus 3 degrees. She says that casually, 3 degrees. Varus is attractive. 3 degrees valgus can look unsightly. So it plays a role in the decision-making process that you say, okay, I'm not going to deliberately put anyone in 3 degrees.
Valgus?
Ja, das ist eine Erfahrung.
Yes, that's an experience. We all want straight legs, but I've been using the method for years now. Yes, for a decade now. And I have to say that most patients are actually happy when their pathological deviation from their constitutional one is reversed. So if someone has always had slightly X legs and they have become really strong, and you set it back to what it used to be, around 3-4 degrees, then they radiate over the straight legs and also have the function that I think it is even permitted with a small or slight valgus. And with varus, it usually looks much straighter afterwards, even if it is 4 or 5
Es
degrees.
ist ja meist sowieso so, dass es hinterher viel gerader aussieht, selbst wenn man bei 4 oder 5 Grad ist.
That's how it is.
So, dann haben wir jetzt ausführlich so über die Dinge gesprochen, gucken mal so ein bisschen und das, was Georg und ich jetzt so...
So we've now talked about these things in detail. Let's take a look. And what Georg and I have presented is actually a bit of a teaser of what has been achieved in science. And we'll now go into great detail. And Thomas Grupp will present the latest developments and the technology that I just talked about, which we need somewhere to ensure safety in the future. Because patient safety and longevity are still something that cannot be ignored. Thomas, we're excited.
bleiben können. Denn die Sicherheit für die Patienten und die Standzeit, die ist eben immer noch etwas, was sich nicht wegdiskutieren lassen. Thomas, wir sind gespannt.
Thank you very much, Henning. I would like to discuss the next steps and advances in phenotyping in personalized knee prosthetics. And today, I'd like to introduce a larger innovation program we're tackling in the hip, knee, and spine. This means Pheno4U, the first application for knee arthroplasty that allows for more customized alignment, not blindly, but with biomechanical evidence.
Vorstellen, die ein individuelleres Alignment erlaubt, aber nicht im Blindflug, sondern mit biomechanischer Evidenz.
If we look at the results in primary knee arthroplasty, then alongside cataract surgery and hip arthroplasty, they are excellent over the long term. For 20-25 years, knee arthroplasty has been considered the best surgical procedure ever. On the other hand, there's a big difference compared to the hip, as we mentioned before, 22. 25% of patients are partially dissatisfied. Georg has shown a study and others are working on it. There are a whole series of studies that all point in the same direction. Gibbon, for example, found in a cohort of 1,100 knee patients that 1 in 5 was dissatisfied with the one-year result.
Und wenn wir uns die McDessie-Klassifikation genauer anschauen, die vorher
And if we take a closer look at the McDessie classification, which was presented earlier, we have to say that McDessie type 5, meaning a straight leg axis and a horizontal joint line, is only found in 15% of patients. The majority of patients, therefore, have other leg axes, such as McDessie types 1 to 3 in the left image, and also McDessie type 4.
zeigt, dass praktisch bei einer Anwendung von
And he has shown that practically when using kinematic alignment in McDessie types 1 and 4, for example, the varus phenotypes, the patients benefit from it because the knee is directly balanced and there is no need to do complex soft tissue releases, which can make the knee insecure, in order to then balance the knee with a mechanical axis alignment.
Und Hirschmann hat diese Klassifikation noch etwas verfeinert.
And Hirschman refined this classification somewhat. In 1.5 degree increments from 308 patients in the cohort, Hirschman described 43 phenotypes. These 8, shown on the right in the image, describe 2/3 of the Caucasian population. The interesting study here is from Max Rudert's research group. Dominic Rack published it from Würzburg.
Die haben strikt
They performed strict mechanical axial alignment surgery and looked at how the patients were doing after a year and found that if you correct a Hirschman phenotype to a strict 0-degree axis, for example, if you set a 5-6 degree varus to neutral, then after a year the patients had worse forgotten joint, Womeg and Oxford knee score. So that's a study that established this connection.
So, das ist eine Studie, die diesen Zusammenhang aufstellt. Und Lorenzo Garrido in Madrid
And Lorenzo Garrido in Madrid went even further. He essentially used the static anatomical image, but then resolved it into a dynamic functional alignment, navigated 0,30, 60, 90 degrees with the orthopilot, and essentially recorded the patients. He then depicted 5 varus phenotypes on the left side of the image and 3 valgus phenotypes.
Valgus-Phänotypen. Und das ist so die
And that is the basis. And we see today, on the other hand, as you mentioned before, Henning, today's knee systems are predominantly designed for mechanical axis alignment. They are developed that way. They are biomechanically tested. And if we are honest, the decades of registered data have always been created in an effort to at least achieve an axis alignment of 180 plus minus 3 degrees. And that has practically given us the reason to develop a dynamic biomechanical knee model. This allows for an interoperative real-time application in combination with navigation and our evidence-based biomechanical corridor, green corridor, as a guideline for patient-specific knee prosthesis insertion. And here on the left, we see many research groups around the world working on complex musculoskeletal models where they can simulate and map patients one-to-one.
Arbeiten an aufwendige muskuloskeletale Modelle, wo sie Patienten 1:1 simulieren und abbilden können.
Heilinen once demonstrated this effort, saying it takes an average of 4 to 6 weeks to image a patient, making it unsuitable for intraoperative use. From there, we derived a simpler model, finite element simulation and musculoskeletal models. They're very powerful and ideal for validating these simulations. I'd like to show why the whole thing is so complex. Let's consider the various influencing factors.
Ich möchte mal zeigen, warum das Ganze komplex ist. Stellen wir uns vor, die verschiedenen Einflussfaktoren.
A Columbus knee has 30 approved implant size combinations, patient weight times 50 to 150 kilograms, with 14 to 25 frontal steps alone. Tibia slope 6 steps, internal-external rotation, and depending on how refined we make it, we have 32,000 to 106,000 calculations. The challenge was to offer this in real time in the operating room.
Echtzeit im OP anzubieten. Wir haben das Ganze validiert. Wir nutzen
We've validated the whole thing. At Bill Taylor's ETH in Zurich, we use the world's most modern gait lab where we practically synchronize measurements on Bergman patients you introduced it earlier who have 6 sensors in the tibial plateau, allowing us to measure forces and moments from the kinematics and kinetics. What does it all look like? Here's an example single plane fluoroscopy. The patient is walking and we can see the fluoroscopy.
Und wir sehen praktisch durch die Fluoroskopie ins Kniegelenk, sehen wir die Bewegung.
Look into the knee joint and see how the femoral joint moves relative to the tibia in AP and also in internal-external rotation. And this is done for these 4 different activities.
Und wir sehen hier dann das Ergebnis.
And here we see the result. The solid line is always the finite element simulation. The spatial moments in the X, Y, and Z directions are the reaction moments here for patient number 2 while walking downstairs on level ground, squatting, and at the bottom of the diagrams you can see the AP translation. Again, the solid line is the FE simulation, and the dashed lines are always the real-world data actually measured in the patient.
Gemessen. Das Gleiche für verschiedene.
The same for different patients, patient 2, 3, and 8 different activities, and it fits together very well. In summary, we now essentially have a dynamic knee model that can determine the tibial moments in the frontal and sagittal planes for everyday activities, and that maps the tibia-femoral contact mechanics. What does that mean? Why is it also important?
Femorale Kontaktmechanik abbildet. Was bedeutet das? Warum ist das Ganze so wichtig? Wir sehen hier rechts im Bild mal so eine Simulation.
We see a simulation on the right of the image. It simulates a gait cycle, for example, climbing stairs. We see the contact mechanics between the femur and the polyethylene. We see the contact stresses, and this is represented by the Columbus deep dish prosthesis with strong congruence. And if we were to take a rather older model for comparison, a Search Evolution, a round-on flat design like a PFC knee, for example, the contact stresses are 1.9 times higher under the same load. And then there are operators who say, come on, 2-3 degrees, what difference does it make? Here we see that an increase in contact stress on the left side of the image increases wear by 9.7 times. So if I increase the contact stress by 2 degrees and I do a linear movement, it doesn't mean that wear increases by 10-20%, it increases by 300 or 500%.
Und wir haben das Ganze jetzt in klinische Umsetzung.
We've now put the whole thing into clinical practice and integrated it into orthopilot navigation. Here we have the patient input parameters: 68 kilo, hip knee angle 6.5 degrees, varus 7 degrees slope. They select the implant size combination, femoral and tibial orientation. Then the moments are calculated in the frontal and sagittal planes, shown in the center of the image, and the contact stress, which gives us an insight into wear and the risk of delamination in the polyethylene.
Als Operateur sehen Sie nur das rechte Bild.
And as a surgeon, you only see the right image. We have this overview in the planning, and at 6 degrees of varus, I could leave the patient. I have a green corridor. Everything is correct with the implant size 4 femur tibia PE selection. With this calculation, you can practically perform the surgery using the kinematic alignment, and it's biomechanically correct.
Hätte der Patient jetzt 100 Kilogramm, dann schaut es schon ein bisschen anders aus.
If the patient weighed 100 kilograms, things would look a little different. Then the whole thing would turn orange and we'd stay at 6 degrees of Varus. Kinematic alignment orange is still okay. This system is very safe. Orange is like the orange traffic light. I can decide to go over it. And if we hypothetically take a very heavy patient, 150 kilograms, then it would turn deep red. Kinematic alignment would definitely no longer be recommended.
Keinen Fall mehr empfohlen sein.
For example, restricted kinematics. If you then go back to 3 degrees of Varus, then it turns orange. Or we go to mechanical access. You can see the green line right in the middle. So in these cases, it's all rather hypothetical. You really have to say that perhaps mechanical axis alignment, survival and long-term outcome of the prosthesis take priority.
Wir haben also einen Planning First Workflow.
And here we see the overview again. So we have a planning first workflow. We have anatomical phenotyping according to CPAC or Hirschman. We then have the choice of mechanical kinematic or restricted kinematic alignment. You can handle it differently for each patient because in the morning the first person operates on kinematics, the second on mechanic. Then we record the tibiofemoral kinematics and we then have this biomechanical corridor which is calculated in real time, available on the operating room screen within seconds to help the surgeon make decisions.
Ja, also ich verfolge das ja auch schon eine gewisse Zeit.
Yes, I've been following this for a while now. It's absolutely fascinating, Thomas. What you've done there is something the entire kinematics world has been waiting for, to get certainty about whether you're allowed to do all this, and now you finally have it. Is it the case that, let's say, with the MDR and approval and so on, that all of this is covered?
MDR und Zulassung und so weiter, dass das alles abgesichert ist?
Ja, ganz korrekt. Also wir hatten erst, ich sage mal,
Yes, quite right. We had, let's say, 6 years of research. We started the program in 2015. We then conducted validations at the LMU in Munich, at the ETH in Zurich, in Rostock, and at the Julius Wolf Institute in Berlin. We have a background of 2.5 billion gait cycles. We've conducted over 400 jaw wear simulation studies in our laboratory since 2000. And we've now structured it so that we fully permit this under the MDR and so that this documented decision by the surgeon is also covered by product liability. So if the surgeon moves with the patient within the green or orange corridor, that's what's stored. In the navigation, it's practically covered by Esculap in terms of product liability and can then also support the surgeon. I'd say it's breaking new ground.
auch unterstützen, ich sage mal, neue Wege.
We have two questions from the audience. You've basically already answered the first one. How was the model validated? Can you perhaps say more specifically which database was used? Was it the Orthoload data or the Bergmann data?
Basis wurde genommen. Waren es die Orthoload-Daten, Bergmann-Daten?
Ja, wir haben das also zweistufig gemacht. Im ersten Schritt haben wir die 8 Orthoload-Patienten aus dem Julius-Wolf-Institut verwendet. Und
Yes, we did it in 2 stages. In the first step, we used the 8 orthoload patients from the Julius Wolf Institute, and that all seems so simple, but the effort lies in the model. To ensure that we don't readjust anything, that means it works for all patients, it works for the averaged results, and it also works for the different activities. In the second step, we went to ETH and also included kinetics and kinematics, where they say we can now also map AP translation and internal-external rotation. And then there's a completely different validation. This comes from the wear lab, where we know very precisely where the limits are for the corresponding implant materials and implant designs, for example, what the contact stress limits are. And there's the point, polyethylene is highly nonlinear. That means if I go above 25, 30 megapascals, the wear doesn't increase by a few percent, but becomes massively progressive. And that's already stored in the system.
ein paar Prozent an, sondern dann wird es massiv progressiv und das ist in dem System soweit hinterlegt.
A second or third question now is whether the simulation model takes ground reaction forces into account, for example, active versus passive kinematics. If I understand the question correctly, it's about whether it was only tested in the simulator, with the implants installed at an angle or loaded at an angle, or whether a gait cycle with the occurring forces was actually tested.
Also, wie ich
A gait cycle was simulated with the forces occurring, as I showed in the image. It was perhaps a bit fast. The fact is that we always work with real-world data, for example, with the measured reaction forces in the patient, namely ground reaction forces, but also the forces in the knee joint, which are significantly higher. So ground reaction force is typically 110 when walking, and if you're striding hard, maybe 125% of body weight. We have the same force in the knee or the same activity in the knee at 300 to 350% of body weight. This was practically depicted here and was used for validation. I'll briefly touch on the topic of active versus passive kinematics later, because I have a few images on that which will probably make it clearer.
And the last question, then we have answered all the current questions, taken into account some comments about the sagittal plane, takes into account here the tibial slope is...
Correct. So in our system, a physiological slope is provided, which means we have 0 degrees of resection and then have 3 degrees of slope in the tibial plateau. But the surgeon has the option of adding more slope, posterior slope, via navigation as well as manual instruments. And that's when you say, I'm going to go more anatomically, maybe in a severe case, I'll do a 7-degree slope, have 3 degrees in the insert, then the sagittal moment might be exceeded due to the patient's weight, and then it will be displayed in orange or red in the software. So as a surgeon, you can, let's say, individualize it, and then you notice if it's getting too much.
But you've certainly played around with the model. The steeper the slope, the further we move away from the 3-5 degrees, the higher the forces become.
Fern nach oben hin, umso höher werden die Kräfte.
The higher the forces become, the higher the moments become. And that's easily explained because we then shift the femoral position more dorsally, and this introduces corresponding bending moments and tilting moments that affect both the anchorage and, accordingly, the polyethylene wear.
I'm really pleased that this rule is being discussed. The next question is already on the ticker. It's also being developed somewhat in the direction of the femoropatellar joint. As I understand the question, that means whether the forces acting on the patella are also mapped out, so that the forces there can perhaps be minimized if the patient has patellar arthrosis.
I mean, you discussed it before too. On the one hand, we actually have to make sure intraoperatively that we achieve reasonable patella tracking and not just look at the tibiofemoral. That's certainly always included in the navigation. On the other hand, we're researching a simulation like this, but it's significantly more complex for the patella because there's much less data available and there aren't yet any proper measurements in patients. Philip Dahm from the Julius Wolf Institute is working with Matthias Waczinski to create a patella as a measurement device. Measurements in patients are difficult today, and approval processes have been complex since the MDR, Medical Device Regulation, and they'll be able to trace them back via the knee kinematics. I'm thinking about the knee kinematics, and then we'll see that we start validating the models. Adrian Sauer in my research group has been working on this, but we won't have it tomorrow.
Ich bin ja grundsätzlich optimistisch, aber das...
I'm generally optimistic, but it will be a challenge because the patella is guided by extremely soft tissue. We're thinking about the MPFL, we're thinking about the lateral pull via the tractus, and many other influencing factors, much more than just tibia femoral. So it will be exciting to see whether we can also predict the patella in this way.
Zu sagen.
Und das ist für mich immer interessant.
And that's always interesting to me, this discrepancy that it's very complex, and on the other hand, there's so little research for this joint, both clinically and biomechanically.
Können wir, Thomas, nochmal zusammenfassen für unsere...
Can we summarize it again, Thomas, for our viewers? Because for many, it's probably very complex. So which aspects do you summarize now? I'll start with body weight, the axis. It's the joint line that you record. And then also the implant parameters?
Implantatparameter, richtig?
Korrekt, weil es spielt eine große Rolle.
Correct, because it plays a big role how I choose the size combination, for example, whether I have a femur 5 with a tibia 5 or whether I choose the tibia 2 sizes smaller. Rotation plays a big role, whether I rotate the femur accordingly. And we also have the topic of the individuality of the axis alignments.
Die Alignments von den Achsausrichtungen.
And each model of your implants is slightly different.
Korrekt, also wer hat ja...
Correct, yes, I showed up to 106,000 calculations. That's just for the Columbus knee. If we then think about the Vega knee, the posterior stabilized knee, or the Emotion as a mobile platform, we have these calculations again in addition. So we've got all that behind us. I've released a large stack of reports, and we're now in the final stages of registration. So the software will be available to the first users around April, so in the second quarter.
Das zweites Quartal zur Verfügung stehen wird.
Great. Does it require new hardware, or is the software installed and off we go?
Die Software wird im Orthopilot, in der Orthopilot.
Software is carried along in the Orthopilot navigation and installed, meaning it doesn't require any new hardware. It's an application, and I'll show further stages in the rest of the presentation, where we'll also get to other hardware.
Prima. Ich denke, das
Great. I think that was a wonderful overview of this complex topic and the details. And we need to recover a bit from this complexity now, but I promise you it's going to get a lot more interesting. We'll take a 10-minute break and then we'll come back with cases. So we'll do it the way we would in the operating room to illustrate everything again. Georg and I have brought cases with us, and we'll hear more then, including about joint play and what else this technology can do.
mehr hören, auch über Gelenk.
So it remains exciting. Take a break for 10 minutes. A small beer helps with all that mental work, and we'll see you again in 10 minutes.
Hilft bei so viel Hirnarbeit und in 10 Minuten sehen wir uns wieder. So, willkommen zurück.
Welcome back to the second half. We're ready to get started, and we'll begin another live vote right away. Please answer the questions.
We were about to ask this question again, but now we're more specific. We're obviously very interested.
Natürlich sehr stark, ob die Zuschauer jetzt
I wonder if viewers might change their strategy now that they know what can be done with Pheno4U software. They would essentially have the same starting situation, a 5-degree constitutional axis and a varus knee, but in a specific case, a 65-kilogram patient, and the questions and answers would be the same except for D. We would now add Pheno4U TKA simulation green corridor, so the patient is on green. How would you now decide on your approach?
auf grün. Wie würden Sie jetzt sich in Ihrer Vorgehensweise entscheiden?
Sehr gut. Und während Sie jetzt noch abstimmen,
Very good. And while you are still voting now, we'll come back later and discuss the results. Let's take a very concrete look at the new world and imagine we were here now and had this new technology at our disposal. And the first case is presented by Georg Maziolis, where he simply demonstrates how it will work later in a standard case.
Ja, vielen Dank. Ich bin gespannt auf das Live-Voting.
Yes, thank you very much. I'm looking forward to the live voting and whether the listeners have changed their minds. CPAC type 5. We've just learned that in about 15% of cases, it's actually predestined for mechanical. I'd like to briefly explain what the numbers mean for those who already have a navigation system, or perhaps who have no experience with it at all. So let's quickly go through them. Here, at the top left, you can see the varus valgus of the femoral component, currently displayed at 0 degrees, which mechanically means 0 degrees
Das
aligned.
gleiche fürs Tibiateil, unten Varus valgus. Dann
The same goes for the tibia part below, varus valgus, then the slope of the tibia. One question related to the posterior slope, which refers to the cut slope. Depending on the implant, there are also 3 degrees in the metal with B. Braun Esculap implants. These are then shown here on top. The load on the tibia part is shown in green or yellow. If it is green, the load for the polyethylene is
als grün oder gelb. Wenn es grün ist, ist die Last fürs Polyethylen in Ordnung.
This is the extension gap. In this case, it can be seen laterally on the fibula. If it opens 3 millimeters on blue, it means it's loosening. If the number turns yellow, it means it's too tight. And medially, it would be 0. That means it would be exactly stable here, corresponding to the flexion gap, which 5 means laterally it opens 5 millimeters, and medially it would be exactly stable.
Und medial wäre das exakt stabil.
Shown here in white at 8 and 9 millimeters is the distal femoral resection. If this is changed, it automatically changes the extension gap. This means that if more is resected, the extension gap will widen medially and laterally by a millimeter, 2 or 3 respectively.
Rechts dargestellt die Rotation der femoralen Komponente und diese
Shown above right is the rotation of the femoral component, and this naturally influences the symmetry of the flexion gap. This means that when you rotate the femoral joint outward, more medial movement is removed and less laterally, thus changing the symmetry of the flexion gap. Shown here is the flexion extension of the femoral component, corresponding to the tibial slope, the slope of the femoral component, and this influences above all on the height of the flexion gap. The more the femoral part is flexed, the more the flexion gap is closed, and the inlay height, just like the height of the tibial resection, has exactly the same influence on the flexion and extension gap.
Tibianresektion exakt denselben Einfluss auf den Beuge- und Streckspalt. Kommen wir jetzt zum Standardfall. Ein Varus-Kniegelenk,
Now let's move on to the standard case. A varus knee joint CPAC type 5, which means MPTA and LDFA.
the mechanical angles of the femur and the tibia are 90 degrees, and you can see that the knee is slightly laxer laterally than medially. Medially, it is stable, with the mechanical limit a moderate
mediales Release erfolgen. Das wird sowohl in Streckung als auch in Beugung.
Widen the gap by perhaps 2 millimeters in both extension and flexion. This will be measured, and here we see the corresponding changes in flexion and extension gaps. Next, the symmetry of the flexion gap can be adjusted by rotating the femoral joint. My personal goal here is to have 1 millimeter more laxity laterally than medially. This doesn't mean absolute symmetry, but rather 1 millimeter more laxity laterally than medially.
Lateral 1 Millimeter mehr Laxität als medial.
After that, the flexion gap still needs to be closed because it opened too wide. This means it should open 2 millimeters laterally and 1 millimeter medially. This can be achieved by upsizing the femur, meaning a larger femoral component only closes the flexion gap.
Alternativ können wir auch beim Femur.
Alternatively, we can stick with the size 5 femur and simply insert the size 5 femur in a flexed position. This would make sense, for example, if the size 6 femur protrudes mediolaterally, or if the tibia would produce a size mismatch with the femur.
Streckspalt zu managen durch die
Then the extension gap remains to be managed by distalizing the femur, meaning by dissecting the lower femur. And you can see that the system displays this white 2-2 dist on the far left, meaning the joint line has been distalized by 2 millimeters in order to close the flexion gap, the extension gap.
schließen. Alternativ, wenn man das nicht möchte, wenn man die Gelenklinie auf keinen Fall.
Alternatively, if you don't want that, if you absolutely don't want to shift the joint line, you can insert a higher inlay. This goes down with the flexion of the femur and thus also closes the flexion and extension gaps. So a higher inlay is obviously the simplest solution. You don't have to play with the flexion of the femur and the joint line, but it can produce a pseudo-patella. If the patella position is already present, it's not recommended.
Ist es nicht empfehlenswert. Flexion des Femurs haben Sie gesehen.
You've seen that flexion of the femoral joint is possible when upsizing isn't possible, for example, when the femoral joint becomes too wide and in summary, CPAC type 5 occurs. Mechanically, you're always alone. That's logical. And it remains biomechanically green because the load is optimally distributed mediolaterally.
Darf ich ganz kurz dazwischen gehen? Can I just interrupt for a moment? If you go back again, biomechanically always green, but perhaps, Thomas, could you also comment again, even in the mechanical alignment case, the slope would then be measured, which means that you would see on the slope whether it turns green or perhaps yellow, which means that you would have an additional effect there too.
Exactly. So we have integrated various things here. First of all, with varus valgus, there we have the axial alignment of the knee.
Grünen Korridor heißt es, dass die Kontaktspanne.
If it's green in the green corridor, that means the contact stresses on the polyethylene are in the green range, meaning the risk of wear delamination is low. If we look at the slope down here posterior, it could be that I specified too much slope, for example, and then sit very dorsally, and that would have an adverse effect on the torque. Then it could turn orange or red. That could also happen with mechanical alignment of a heavy patient with a lot of slope.
Viel Slope passieren.
And on the far right of the image, where we have the tibial plateau in top view, we can see the contact situation laterally and medially, and how the moment arises in the frontal plane. And here, of course, it's green, because mechanical axis alignment, as already mentioned, is the ideal starting position for the load and for the anchoring of the tibia plateau.
Vom Tibia Plateau.
Ist das so ein normales Gelenkspiel? That's how a normal joint works, Georg, as you set it up. If you go to the nearest millimeter and you said a little bit of lateral liftoff is acceptable, that's a typical picture.
Das ist ja eine Simulationssoftware, die wir jetzt.
This is simulation software that Isculab has provided us with. The real version isn't available yet, so I was able to work with my ideal values, and that's exactly the situation I want. That means a medial extension gap of 0, a lateral 1 millimeter, and a flexion gap plus 1 millimeter each. That's my personal goal.
Persönliches Ziel ist.
Ja, und hier gelöst über ein höheres PE.
Yes, and solved here with a higher PE. Additionally, I'd like to add something. Navigation led us many years ago to also offer narrow sizes. That means if you say, as you also showed, you could go from a femur 5 to a 6, if the ML then becomes too wide, we would have a 6 narrow, which has the AP measurement of the 6 and the ML measurement of the 5. So that was what guided us. Our narrow sizes were essentially developed based on our navigation experience.
Praktisch basierend auf den Erfahrungen der Navigation entstanden.
Und wenn man jetzt den Blick mal von der Bein...
And if you now shift your focus from the leg axis to the geometry of the bone, then these white numbers 8, 9 on the left side and the distal resection 8, 10 on the right side also help you see whether you've significantly changed the geometry or not. I know that a size 5 femur has an implant thickness of 9 millimeters, and I know that I can change less than 1 millimeter at a time, thus changing the geometry of the femur as little as possible in this case. Change, and that would be precisely the goal of the procedure, not just to look at the axis, but also how much change can I expect from my two condyles, distal and posterior. That's actually the philosophy of kinematic alignment. We try to change the transcylindrical axis, that is, the distal and posterior femur, as little as possible in terms of height and resection. The navigation shows me that, along with the entire axis, of course.
Das heißt, distales und posteriores Femur möglichst wenig in der Höhe und der Resektion zu verändern. Und das zeigt mir die Navigation neben natürlich den Ganzachsen an.
Ich denke, wir könnten mal schon mal...
I think we could move on to the next case. And let's think together about what changes if we move on to a kinematic case. We have a really classic case, not too crooked, but still, if you look closely, a case where you have to think about the weight. 95 kilos, 178, 77. You can see how to do it that way, and if you do it kinematically.
Wenn man auch schon mal über das Gewicht nachdenken muss, 95 Kilo, 1,78, 77. Man sieht, wie man das so macht. Und
After surgery, I always strongly recommend giving a lot of thought to what will happen afterward, so you can compare the final result with your plan. And I recommend always going through the process and looking at the previous angle. It's measured at 5 degrees. Then we have the tibial tilt angle, the varus in the tibia, the MPTA at 85, which is already quite a lot.
den tibialen Neigewinkel, also den Varus in der Tibia, den MPTA mit 85, das ist ja schon eine Menge.
Is that something you were afraid of in the past? Cutting a 5-degree varus into a tibia, Georg?
Definitiv. Allein schon die Kritik in der Frühbesprechung.
Definitely a hindrance just for the criticism in the morning meeting. It's now established, cinematic screen, but as soon as you move away from 3 degrees, it's definitely thin ice.
Dünnes Eis. Definitiv.
Und Thomas?
Thomas, can you tell us whether we should be worried about 5 degrees, right?
Oder?
Also,
So, with the patient's weight, I think there's still room for improvement. We'll see what the simulation results look like, but I think it's still doable. From a purely intuitional perspective,
Gut, also wir haben dann auch den...
It's good. We also had the valgus in February, the joint line, and so on. The arithmetic angle is basically the sum of the MPTA and LDFA, which is what we should ultimately get. So, with these values of 85 and 88, we're going into the race.
Oben eingegeben, 95, suchen uns die Prothese.
We've now entered the patient's weight above 95. We're choosing the prosthesis. As you've heard, it does matter which prosthesis you choose. Size is entered, LDFA and MPTA. Just like Georg, I also added a millimeter to the lateral flexion gap and left the knee a bit loose. I entered KA, which is kinematic alignment, and then you switch to this screen and see what it would look like. Of course, we have now a great kinematic representation. The same number of millimeters are removed from the distal gap, for example, the distal femur, namely 9 millimeters, as will be added later with the prosthesis. When you look at the femur in the flexion gap, 8 millimeters are removed. That's exactly the prosthesis, which essentially has different thicknesses distally and posteriorly.
8 mm abgenommen, das ist exakt die Prothese, die im Grunde genommen ja distal und posterior unterschiedliche Dicken hat. Und Sie sehen, dass dann oben links in der Ecke sieht man, dass der...
And you can see that in the top left corner, you can see the hip-knee angle or ankle angle. It's 3 degrees, which is exactly our calculated arithmetic angle. So that would be the target, and it's beautiful to see. At 95 kilos, we're green here, right?
correct, yes.
So I could just say go.
Go, green corridor, everything's biomechanically well constructed, and I think from the supply strategy, ideal for the function of the patient.
Ideal für die Funktion des
And Georg, I could now save myself all the balancing steps, right?
That's how it is. That's the huge advantage of kinematic alignment. And if you have the security of going up to 5 degrees here, you save yourself a release completely.
Well, you can then, as Georg has just shown, think again about the joint play, whether you want it loose or tight. That would probably be too stiff now. But that is, again, experience that everyone has to gain from their prosthesis.
seiner Prothese machen muss. Deshalb ist Knieendoprothetik ja auch.
That's why knee arthroplasty is still not entirely mechanical, but requires a certain amount of feeling. So we can see that it doesn't change anything if we change the joint play. We can now set it back to mechanical, but then we say, no, that's all too risky for me, even though there's really no reason to, and we can see that it would be much easier this way. That would be the purely kinematic aspect.
Eigentlich das so fast viel einfacher wäre. Das wäre jetzt das rein kinematische. Und zum Schluss noch.
And finally, just to illustrate this case, if we make a mistake by 1 degree, well, let's put it this way. We make a small mistake and we see that we've increased the varus, the MPTA, the tibial varus, by 1 millimeter. Then the whole system immediately switches to yellow. Yellow is still okay, Thomas?
Gelb. Ist Gelb noch okay, Thomas?
Also es ist sehr viel Sicherheit im System.
You shouldn't lose sleep if you say you planned for 3 degrees and ended up with 4 degrees. You don't need to think about the case any further. It will have good long-term stability. If it turns red here, then I would change my plan again. I would adjust the prosthesis at that point, rethink it, and treat the patient somewhat differently.
Justieren und nochmal nachdenken und den Patient etwas anders versorgen.
Theoretically, you could make it really complicated and then see how it would work with a different prosthesis. I haven't modeled it, but based on your information, it would also be worth considering whether there might be further biomechanical improvements, right?
Sich noch verbessern könnte, richtig?
Ja, also da
Yes, for example, the size combination plays a role. If you say, come on, could I perhaps go for a tibia or femur one size larger? Then I'll have a bit more reserve. And that's also the part. If someone is very heavy and needs a very small joint, for example, then the corridor becomes very narrow and vice versa.
dann wird der Korridor sehr eng und andersrum.
Es sind Fragen reingekommen.
Questions have come in, perhaps one that has to do directly with the device or the software can be answered, namely how is the surgical data recorded or stored post-operatively? Does it flow into a database and is it then incomparable and can it be evaluated?
Ja, also ich gehe nachher noch auf.
Yes, I'll talk about the next steps in the future vision later. Currently it's stored in the AuthorPilot, which is available to you as the surgeons for the case, and is also stored there forensically, so to speak, so that you can always provide evidence. We're not yet at the stage where the systems communicate with each other in terms of connectivity to a health cloud. We're working on that.
Systeme miteinander kommunizieren. Wir arbeiten
because we can then, of course, combine various information from the clinic, risk predictors, other patients, accompanying symptoms, comorbidities, and so on. However, that's not possible in the current version. Currently, the location is stored on the AuthorPilot and is available to the surgeon as a file.
und steht von Operateur als File zur Verfügung.
So there are no data protection concerns?
Rechtlichen Bedenken.
Nein, also da hat sich nichts geändert.
No, nothing has changed compared to the last 20, 25 years. From a technological perspective, unfortunately, yes, because these new technologies via cloud-based applications allow us to do things like record pre-op patients. But at the moment, this data is stored on AuthorPilot. We started in 1997 and have many years of experience, so nothing else has changed, just a new application.
Und dann schon viele Jahre Erfahrung, also ganz normal, hat sich nichts weiter geändert. Nur eine neue Applikation.
Gut, wollen wir ein bisschen extremer werden, ja?
Okay, do we want to get a bit more extreme? Yes, let's take another case. Let's move on to the next case presentation. Here we have a 71-year-old lady, 65 kilos and 1.71 millimeters, so everything is within the normal range, but you can see that the varus is quite significant. And if we now carry out our analysis as we just did, we can see that there is a varus of 13 degrees. Georg, a lot of people always think, oh God, I 13 degrees, but that's not 13 degrees at all.
Aber das ist ja gar nicht 13 Grad, ne?
Nee, also bei der Analyse muss man...
No. So in the analysis, you have to differentiate between what is a bone cartilage defect, what is an extra-articular deformity, and what is ligamentous instability. And as a rule, it is a combination of all three factors.
Den intradikulären...
If you remove the intra-articular defect and the instability by tightening it with an inlay, all that remains is the extra-articular deformity. And that's precisely the constitutional deformity we want to preserve. I hardly know of any cases that end up at 13 degrees constitutionally.
Und ich denke, das ist auch genau das, was man hier sieht.
Exactly, and I think that's exactly what we see here. When you measure the varus angle of the tibia, the MPTA, it's quite pronounced at 8. Angle of the distal femur, for example, the LDFA crap at 87. Then at the end you get an arithmetic angle again, for example. What the knee actually was constitutionally at 5 degrees, and that sounds a lot more civil, if I may say so, than the 13 starting value, but still 5 degrees at 65. Now Thomas is coming again with your prediction.
Den Ausgangswert. Trotzdem, 5 Grad bei 65. Jetzt kommt wieder Thomas mit deiner Vorhersage.
I think that should still be within the green range and allow plenty of leeway.
Okay, let's take a look. So we're back on the first screen. It's not 100 kilos, so you enter the 65, the LDFA, the MPTA, the size, and again the prosthesis, kinematic alignment, and again this standard joint play with a millimeter everywhere.
Kinematisches Alignment und wieder diesen Standard-Gelenkspiel mit überall 1 Millimeter.
Laterally in the flexion gap, 1 more millimeter, and anyone who's ever played around with kinematics or thought about it can do that. This ultra-symmetrical flexion and extension gap is no longer the goal in the kinematic world. Instead, you always try to make it a touch looser laterally. And if you go into the race with this model, you'll see that you're balanced, that you've got exactly that.
Dieses Modell jetzt in
Cuts off the bone, which the prosthesis puts on. Classic kinematic. We didn't make any mistakes in our plan either. You can see in the top left corner that the leg axis angle is 5 degrees, and you can see that we're green. Yes, who would have thought that?
Achsenwinkel 5 Grad ist. Und man sieht, dass wir grün sind. Ja, wer hätte das gedacht?
Trotz der 8 Grad.
Despite the 8 degrees on the tibia, you would certainly have imagined that without such biomechanical support in the operating room, you would not have risked it.
Und ich denke, das sind
And I think those are values. So you almost still can't believe that you can trust this thing. We're just at the beginning, I dare say, but it's been a very, very impressive experience for all of us to play with these things and get a sense of security, because the leg axis angle obviously plays a bigger role than the joint line inclination angle. That's probably something that's a bit interesting for you too.
Beinachswinkel eine größere Rolle spielt als der Gelenklinienneigungswinkel, korrekt? Siehst, das ist für dich auch sicher etwas, was so ein bisschen interessant ist.
It's like this. It corresponds to the height of the adduction moment, and with the leg axis angle, the lever length increases, which affects the center of gravity, and the longer the lever, the load increases proportionally. That's clear.
Nimmt die Belastung zu. Das ist so, klar.
The other, in turn, causes shear forces. So if I set the joint plane too crooked, with every loading step, I get a shear load on the femur against the tibia, so that also has to be limited somewhere.
Das muss irgendwo limitiert bleiben.
Gut, dann schauen wir uns die Simulation noch mal weiter an.
Okay, let's take a closer look at the simulation. Here too it shows that if you change the joint play, for example, make it tighter in the extension gap, that this has no effect.
Die Lasteinwirkung hat.
The load effect can't be derived biomechanically, so that would be... You can also see that a change in rotation. Now you can say, for example, okay, let's make it symmetrical, actually has no influence on the load, except for the weight notching shown above. But you could now consider what would happen if we increased the weight dramatically, more than doubled it, and I've entered 140 here.
Dramatisch erhöhen, also mehr als verdoppeln. Und ich habe jetzt hier einmal...
We don't want to hope that the woman gains that much weight, but let's assume we have these morphological parameters and 140 kilos. Thomas, your prediction.
Thomas, deine Vorhersage?
Also ich würde
Well, I would expect it to turn really red, and then we'd see that we're way over the limit and have to rethink our strategy and surgical technique.
und die Versorgung überdenken.
Und das ist
And that's actually the case. It's quite interesting to see that the entire green corridor at 140 gets really narrow.
bei 140 richtig eng wird. Es ist fast alles gelb und wir sind hier schon rot.
Almost everything is yellow, and we're already red here. This shows that operating on overweight patients involves a completely different safety dimension than we always thought. We all know the complexity of such patients, but this seems to exaggerate it even further. If you look at 3 and 8 here, then you absolutely can't do that, and I suspect you can't play around with the size much either.
Das darf man dann also auf keinen Fall machen. Und ich vermute, da kann man auch jetzt mit der Größe nicht viel spielen.
I think if you look further and say, I'm going to do restricted alignment, I'm only going to take off 1 degree, then interestingly enough, you can see that even with this huge weight, you're already in the yellow area.
Da hat es verschiedene Hintergründe.
There are a number of reasons for this. Firstly, the Columbus deep dish system is very robust, with top long-term results in the register across the country in England, Australia and Germany, and that shows that the system is very robust.
Dass sehr viel Robustheit im System eingebaut ist.
Polyethylenes are also mature developed. On the other hand, at the AE Congress in Dresden in December, we discussed a lot about obesity, about patients with a BMI over 40. We also see in the registry that the downtime decreases significantly, and with such a patient, you certainly have to consider whether to take certain, let's say, approaches, or say, come on, then I'll just do mechanical align or restricted kinematic align. And you can also see how narrow the corridor becomes There are even patients with unfavourable size combinations, small size or large difference in the tibia and femur, where the corridor becomes as narrow as 3 degrees. This hypothesis of 180 plus minus 3 degrees over decades is very poorly supported by the DA knee, never based on a relatively small number of patient cases, but it has only become established in the professional world. But the software can also help me with that. For patients with high body weight and unfavourable size combinations, saying, okay, I know the corridor is getting narrow, I have to be careful about that, and I really have to look at the long-term results of the long-term prosthesis and then proceed accordingly.
Eng, da muss ich achten drauf und da muss ich eigentlich schauen eher auf die Langzeitergebnisse, Standzeit der Prothese und dann halt entsprechend vorgehen.
Georg, was wäre denn deine Strategie?
Georg, what would your strategy be in a case like this? Still doing something kinematic, but now restricting it? It's more likely to be done on the femur or on the tibia or on both. What would be your philosophy?
An beiden, was wäre deine Philosophie?
Bei einem solchen Fall mit einem derartigen Übergewicht wäre ich.
In a case like this, with such overweight, I would be cautious with kinematical alignment in general, and I would quite simply use a tibia stem and probably align it mechanically for safety reasons, and only after I've gained some experience with the software and have gained confidence. I also dare to go to 3, 4, 5, or 6 degrees. It's yellow, it's permitted, and you've built in a safety corridor, which means it's okay. But as a human, as a surgeon, you probably still need a bit of confidence in the technology.
Eingebaut und das bedeutet, dass es okay ist. Aber man braucht als Mensch, als Chirurg dann vielleicht doch noch ein bisschen Zutrauen in die Technik.
Thomas, your orthopilot is a very proven navigation system. Can you be so precise with it that you can hit that spot exactly?
Präzise sein, dass man das jetzt genau so trifft und
So you can get this corridor of plus or minus 1 degree, you can be that precise. You don't have to stick strictly to the screen where you say, yes, it will be half a degree more. It doesn't really matter. You certainly have other clues. For example, on the right of the image, you can see that it turns orange medially in terms of the frontal moment, for example, the tibial anchorage. As you say, Gary, you might also need to assess the patient's bone quality, etc. You can consider this in the operating room, and this information is always available in real time. You change a degree by 2, you see the result immediately, and then you can make a decision and move on with the operation.
Das Ergebnis und kann dann entscheiden und weitergehen in der OP.
Jetzt haben wir eine Zuschauerfrage.
Now we have a viewer question regarding the reference to shear forces and joint line obliquity.
Obliquity, also der Schrägstellung der Gelenke.
So the inclination of the joint plane, how much varus valgus inclination of the joint plane is still tolerable in terms of shear forces, for example, biomechanically? That is how crooked can the joint plane be placed in varus or valgus while maintaining a straight leg axis?
Also da ist
Well, it's certainly true that you can't generalize. I've always resisted this. I've often been asked how many degrees of hip-knee angle I can achieve. Can your knee system achieve 6 degrees? You can't generalize. We've shown that it depends very much on the patient's weight, it depends on orientation, on size combinations, and vice versa. There's some certainty there. If the system shows 7 degrees, for example, on the tibia, that would still be okay for the patient. Then there's sufficient reserve. So just to give you a sense of the orange to red, the whole thing increases by another 25%.
Orange auf Rot, da steigt das Ganze dann nochmals 25% an.
Okay, also man kann keine pauschale Antwort.
So you can't give a blanket answer, you just test it in the system, and the system will tell you where the polyethylene load limit is, including in terms of shear forces. Now, of course, there's a completely correct indication. At 7 degrees of varus in the tibia, I'll have problems with the tibial stem, right? Yes, if I don't have constitutional varus. Usually, however, the varus is metaphyseal varus, meaning I have the axial kink extraticular in the metaphysis. So I'm actually already in varus in the proximal tibia, and at least in a short stem. No problem. Of course, if I were to use a very long stem, which I wouldn't recommend prophylactically in such a case, then you'd probably hit the lateral corticalis at some point, but otherwise on long knee radiographs, not full leg radiographs, but long knee radiographs. A kinematically inserted tibia looks partially straight ahead because it follows the constitutional shape of the tibia.
Formgebung der Tibia folgt.
Aber es ist doch wunderbar, dass wir jetzt
But it's wonderful that we're already at a point where we're discussing whether we can go up to 7 degrees or not, or whether that's still okay with the implants. And I think we can close the case by saying that when we're 140 kilos, we might try to go green again, and we'll all take another look and actually say, the old world wasn't so bad, and move forward cautiously. Good. Then I think we'll move on to the results of the second vote.
Dann denke ich, machen wir weiter mit den Ergebnissen vom zweiten Voting.
Ja, genau. Oh, da hat sich aber sehr...
Yes, exactly. Oh, a lot has changed in the first vote. We had 48% in the standard plus 3 degrees. I wouldn't have expected that now 60% would be in kinematic alignment 5 degrees according to the structural axis and use Pheno4U so that it would be like this. This change in strategy is coming quickly. I don't know how you think about that.
Die Änderung, ich weiß nicht, wie ihr euch das vorgestellt habt.
Ja, ich denke, das ist das, was...
Yes, I think that's what you often hear, that everyone is convinced that functionality will actually improve simply through kinematics. The evidence is so clear, and that essentially only this safety aspect hasn't been fully clarified and is also complex, as we've learned today. It's all the better that we now have technology that can help us move forward. But the technology offers us even more, and in addition to the certainty of whether or not one can do kinematic alignment, we also have to look at the knee dynamically, and we talk a lot about joint play and whether we can do this in all knees, and now we're back to phenotype and personalization, whether we can do this in all patients. The same joint play and the same knee kinematics should be set according to the sentence, we do PS, and then everything goes backwards, or we just don't do it. And there have been a lot of ideas recently that say that natural knee kinematics have something to do with rotations, with pivotation. People talk about medial pivotation and so on, and that is something that is interestingly related to the software and the scientific development at the company Esculap, a decisive step forward. And before Thomas Grupp presents these details to us, we want to do a live vote and ask ourselves the following question. This look, which may already be clear to some, is the so-called Pinskerova look, which indicates that the knee possibly...
einen entscheidenden Schritt weitergekommen ist. Und bevor Thomas Grupp uns jetzt diese Details darstellt, wollen wir auch noch mal zu einem Live-Voting gehen und stellen uns folgende Frage.
You can see medial at the big C and lateral on the right, and now you can see that it rotates medially and rolls laterally backward. This is the famous lateral rollback, and from all these scientific aspects, we all assume that this is a kinematic principle, which we all have, but now we're back in the world where we may have to personalize.
Laterale Rollback. Und von diesen ganzen Wissenschaftsaspekten, Freeman, Pinskerova, gehen ja wir alle davon aus, dass das ein kinematisches Prinzip sei, was bei uns allen vorliegt. Aber jetzt sind wir wieder...
And I think Thomas Grupp will show us again what's possible with Orthopilot and all the scientific aspects of pivoting.
Zeigen, was mit dem Orthopilot und den ganzen Wissenschaftsaspekten zum Pivotieren möglich ist.
Herzlichen Dank. Ja, ich möchte in einem weiteren Schritt jetzt die Zukunftsvision zeigen, weitere Stufen von Pheno4U.
Thank you very much. Yes, I'd like to show you a further step, the vision of the future. Further stages of Pheno4U that we're currently developing, and also what biomechanical evidence and scientific background we have to do this. I'd like to give a brief overview. I'd like to start with a large-scale one, examined at 3 multi-center centers in Constance, Madrid, and Dublin. Essentially, the passive movement was recorded, the kinematics were recorded intraoperatively, and then in this image, the condylar line was projected onto the tibia.
In diesem Bild hier praktisch die...
In the center, you can briefly see how this works. Medially, we see a pivoting movement as just described. According to Pinskerova, medially from 0 to 90 degrees of flexion, it's more of a pivoting movement, and laterally this rollback. When you go to conferences these days, you think that everything should actually function like this. This medial pivoting movement is often postulated, and we wanted to take a closer look.
Auch eigentlich müssten alle so funktionieren. Also es wird sehr viel dieses mediale Pivotieren postuliert. Und wir wollten es mal genauer anschauen. Hier sehen wir nochmals die 3.900 Patienten.
Here we see the 3,900 patients, again the medial and lateral point clouds, showing how the individual patients are represented here at 30, 60, 90 degrees flexion, and now we get the overall picture, and we were quite surprised. We see the medial pivoting up here in the first row, and we see the classic medial pivot. Lateral backward movement occurs in 49% of patients, so every second patient falls into this pattern, but not everyone. Then we see practically no pivot in the midline, or a central pivot on the far right, the central pivot, where the pivot point is actually centrally located on the tibia. We have 9% of patients on the far left who show no rollback at all, meaning they remain centrally aligned with the axis. We also have 16% of patients who show massive symmetrical rollback, meaning they rotate back almost equally medially and laterally. And we even have 14% of patients in the bottom row who show lateral pivoting. This is the picture from a cohort of 3,900 patients.
Wir haben sogar Patienten unten in der unteren Zeile, insgesamt 14%, die ein laterales Pivotieren zeigen. Und das ist also das Bild aus einer Kohorte von immerhin 3.900 Patienten. Und wir hatten ja
And we had the audience question before, where I referred to now, where they say, yes, you record the passive. In the operating room, you do a passive movement through. That has nothing to do with everyday life when the patients are standing on it. And that interested us. We have a 6-axis robotic system, the anti-vivo. We had different knee preparations, and then we looked at when we let the robot simulate a passive movement through the operating room. And if you then perform an active stair climbing cycle like Bergman's on the same knee specimen, which is of course highly controlled in this robotic system, the axes, the orientation of the femur and tibia, are measured very precisely via digital image correlation using the point clouds, and there we see the result. On the left in the image, you can see the passive flexion and then the stair climbing cycle.
Bild sieht man die passive Flexion und dann den Treppensteigzyklus.
Overall, the patterns aren't all that different, and we can also see the mean values on the right side of the image. And if we look at the image here, a specimen on the right side of the image shows passive flexion, with native kinematics from 0 to 90 degrees at the top, then slightly different when climbing stairs. And then if we insert a CRCS here, we notice that this doesn't reflect the patient's kinematics. And if we then go to the very bottom right and install a PS knee, then it would both passively and actively replicate the Pinskerova pattern relatively well for this patient. Another part that is often mentioned is that when we perform bicondylar knee replacements, we always resect the anterior cruciate ligament. Some say then everything is different anyway, so we wanted to investigate that as well.
Auf jeden Fall das vordere Kreuzband. Manche sagen, dann ist sowieso alles anders. Auch das wollten wir mal untersuchen, weil wir zunehmend erfahren möchten, welche Muster sind denn verletzt.
Because we increasingly want to learn which patterns are reliable and less susceptible to change, and which ones I can't rely on at all. And here we use the robot again. You can essentially see the overlay of the CT images of the bones matched to the robot via image correlation, and then the movement through them with the condylar line projected onto the tibia again. And here we see the diagram showing 0 to 90 degrees in this image. Specimen number 8 would be a centrally positioned specimen which has little rollback, both medially and laterally. You can also see that in the right-hand image, the solid line shows the medial rollback from 0 to 90 degrees. The dashed line shows the lateral rollback, which is almost equivalent, I'd say, around 67 millimeters, if we've preserved both bands, green. If we resect the anterior cruciate ligament, blue, and if we resect the posterior cruciate ligament, red, the basic characteristic on the left in the image is not changed. This remains a patient who shows the kinematic pattern centrally with little rollback. Another example, number 12, here we see a very classic pronounced medial pivoter.
Hier sehen wir einen ganz klassischen, ausgeprägten Medial-Pivotierer. Man sieht wieder oben die durchgezogene Linie Nahtieferzustand, beide Kreuzbänder.
You can see the solid line again above in the near depth condition. Both cruciate ligaments receive 3 millimeters of rollback at 90 degrees medially and 21 millimeters of rollback laterally. If we then resect the anterior cruciate ligament, blue, the characteristics change only slightly. And if I resect the posterior cruciate ligament, the gap naturally opens up. We all know that, but the basic kinematics remain the same.
Und das hat uns jetzt dazu geführt, das Ganze dann auch belastet anzuschauen.
And that led us to look at the whole thing under load in the Munich knee cinematographer. This has the advantage that we can depict a deep squat up to 130 degrees of flexion. 20 near-depth knees were used here with this deep squatting movement. And we can see two examples on the left in the image. Basically, a patient who from 70 degrees of flexion to 130 degrees of flexion shows about 15 millimeters of rollback.
Ein PS-Kniesystem von uns sehr gut passendes. So bei
Purple would now appear. One of our PS knee systems fits very well. It intervenes at around 60 degrees and then maps this rollback. If I do a deep dish, consistently saying I only do CR or deep dish, then we see that from 100 degrees onwards it no longer matches quite so well. For me, the right case is even more meaningful if I say this is a patient who has 5 millimeters of rollback, and I map this well with the deep dish.
Wenn ich sage, ich bin aber ein PS-Fan, bei mir bekommt jeder.
If I say I'm a PS fan, everyone gets PS from me, then I force them into a rollback of 20 millimeters, which they probably never had. And I think that these are perhaps the patients where you say, I did everything right. The implant size selection was good, the balancing was good, the alignment, everything was in the green zone, and I don't know why they aren't satisfied.
Und ich weiß nicht, warum der nicht zufrieden wird. Und das sind eigentlich Dinge, die wir heute nicht erkennen können. Wir wissen nicht,
And these are things we can't actually identify today. We don't know what the kinematics will be like in the patient, and so we went further. We then built the One Knee platform, which essentially includes the CRCS, MSLS, PS, and PS Plus gliding surface variants, all on one tibia, 2 femora, PS and CR. So even from a consignment point of view in the clinic, the effort surrounding the operation remains manageable.
überschaubar bleibt. Die Plattform wurde mit der Simulationssoftware.
The platform was developed with the simulation software using the Iscolab model. We have what we have in the Pheno4U and software. We've now conducted a study with the robot again and then incorporated the various gliding surfaces, CRCS, MS and PS. There we can see the corresponding AP patterns and rotation patterns of the patients. And on the right in the image, you can see the entire knee.
Dargestellt. Das mediale Pivotieren.
The medial pivoting when I am at the very bottom right, when I install a CR gliding surface and when I install an MS gliding surface and when I install a CR gliding surface in the same knee, then I am diagonally above, so I have a central pivoting, so I change the kinematics of the knee joint for the patient via the gliding surface.
Gelenks für den Patienten. Und da ist es jetzt so, dass wir über die
And now we can map all the recorded patterns from the 3,900 patients using the One Knee platform. CRCS is central symmetric rollback with PS or PS Plus. I use PS Plus if I still have varus valgus instability and can also map LS and MS in the next step. In the next step, we perform the anatomical phenotyping here on the left side according to CPAC.
Hier auf der linken Seite die anatomische Phänotypisierung machen nach CPAC. Wie schön gezeigt in dem Beispiel.
As you clearly demonstrated in your examples. And now we have this kinematic image from 0 to 120 degrees Pinsker-over view on the right screen. And in the overall overview, I'd like to briefly show how it looks. So we have the patient here, we have the anatomy, we then consider implant size, we have the topic of surgical experience and what insights flow into the patient.
Thema chirurgische Erfahrung, welches sind die.
You also have patient-specific considerations. What other accompanying issues need to be taken into account? We've essentially presented the kinematics here, as shown in the image. We'll have an algorithm that will then recommend which knee implant types are suitable for the patient. There will be a selection, the surgeon will remain the decision maker, but things will also be ignored. I'd say we work against the patient's kinematics. We then have the biomechanics simulation for axis alignment and biomechanical loading, and can thus treat the patient.
Gegen die Kinematik des Patienten arbeiten. Wir haben dann die Biomechanik-Simulation wieder für Achsausrichtung und biomechanischer Belastung und können so den Patienten versorgen. Und vorher war noch die Frage mit dem Thema.
And before that, there was the question of what about the data, about the connectivity. We're working on integrating things into a data platform via a cloud, because then in the third step, we want to develop a gait lab. ETH Zurich has an incredibly sophisticated gait lab. We want to get to the point where we can use a cuff in every clinic to load a patient in 5 minutes, such as when I'm walking, using stairs or sitting on a chair. Record the patient's kinematics and then pre-analyze them. Whether we should consider how to care for the patient, and of course I can only achieve that via connectivity.
Hast du eigentlich schon eine Zuschauerfrage beantwortet?
You've already answered a viewer question. How can I determine if a knee is pivoting medially? Currently only with navigation or fluoroscopy, in the near future via a device that is point of care, meaning everyone can use it in their hospital, right?
Nutzen kann.
Das ist unsere Vision.
That is our vision. With the simulation, as I showed before, I also had 4 to 6 weeks of simulation for one patient. I always told my team that I wanted it on the screen in the operating room in 10 seconds. Only then would it be usable for the patient's treatment path. We're doing a lot of research on the cuff. We're currently validating it with Zurich, and I'd say it will probably take us 3-4 years until it's available as standard and at a reasonable price in every hospital. Otherwise, my only option today is to record intraoperatively via navigation and then make my selection.
Operativ aufzunehmen und kann dann meine Auswahl treffen.
Aber ich denke, wir sind ja jetzt in einer Welt, wo wir überhaupt mal über Dinge nachdenken, die wir früher...
But I think we're at the right point now. In a world where we're actually thinking about things that we never considered before. And now perhaps it would be interesting to look at the voting in connection with the lecture again, to see how many people actually considered the medial pivot as a knee, as a standard knee. Perhaps we'll see that most people were of the opinion that 80 to 100% is medial pivot, and that's, let's say, only 50. If it was 40 to 60, that would be fine. Yes, that's interesting, and that's exactly right. So now the way it's being displayed is that we can actually say from your data that it's half, right?
60 würde passen, ja. Das ist interessant und das passt, genau. Also jetzt, so wie es jetzt eingeblendet wird, ist das so, dass wir tatsächlich nach deinen Daten sagen können, die Hälfte ist es, ne?
Ja, genau. Also ich hätte nicht damit gerechnet.
Yes, exactly. I wouldn't have expected that because when you're at conferences, you think 100% is media pivot. You hardly hear anything else, but you can see that the surgeon's instinct probably closer to reality.
Die Realität dann nahe kommt an der Stelle.
Sehr gut. Wir kommen so langsam.
Then it's very close to reality at this point. We're slowly coming to the end of our academic hour here in knee arthroplasty, so perhaps we can summarize the take-home message from you, Georg, on the Pheno4U methodology and principles.
Also auf der einen Seite,
On the one hand, it allows for enormous security that we didn't have before. We remember our case with 8 degrees varus. On the other hand, looking ahead, we're also looking at the phenotyping of the kinematics, where we'll have more than just gut feeling right now. Let's leave the lateral joint a bit looser. No, then we can measure it. That's a lateral pivot, and we're not doing it any good with a medial pivot prosthesis and vice versa, and I believe that's the future. That's a sensible use of navigation.
vice versa. Und ich glaube, dass das schon die Zukunft ist. Das ist ein sinnvoller Einsatz von Navigation.
Für mich ist es
For me, it is like this. I think that the decisive parameter is that we do have to understand a little bit of everything that Thomas Grupp has told us, but that in the end it will reach us in the clinic in a very simplified form because we will have a traffic light in the navigation system, and with one knee, that is this new knee prosthesis system, which will come. We'll have the possibility to react to different joint play principles.
Prinzipien zu reagieren.
And I think that's what leads us perfectly into the new world. And I think, Thomas, you offer us clinicians an excellent, or you and your colleagues offer us an excellent, interesting new world. We don't want to overcomplicate things, but I have to say, personally, as someone who has been working in this world for quite a long time, I have also relatively internalized the principle. I'm looking forward to having these opportunities because I believe the work will improve even further. I'd like to thank everyone, both of you, for presenting this in a, let's say, quite elegant and understandable way. We would be very pleased if you would give us some feedback. You can do that now simply via input, and we might want to repeat this in the future.
Haben, weil ich glaube, die Arbeit wird dann doch noch besser werden. Ich darf ganz herzlich allen danken, euch beiden, dass das so, sagen wir mal, doch recht elegant, glaube ich, und auch verständlich dargestellt wurde. Wir würden uns sehr freuen, wenn Sie uns ein Feedback geben würden. Das kann man einfach jetzt auch über Eingaben machen. Wir wollen das in der Zukunft möglich.
It was a wonderful evening for me too, where I learned a lot. I wish you all the best. We'll see each other again in the big wide world of personalized knee arthroplasty, and I hope for the best for us and our patients. Goodbye.
Und hoffe das Beste für uns und unsere Patienten. Auf Wiederschauen.